Ahead and get started. Welcome to the second afternoon session of the 2023 Culture of Data Conference, sponsored and produced by the Colorado Public Health Association. Our session today is broadening the definition of public health practice and partners. Thank you all for joining us. I am Kim Boyd. My pronouns are she, her, hers, and I'm going to be moderating the session today. If you would like to update your name or your pronouns in your how your name is showing up on your Zoom screen, you can hover over yourself and go to the three dots, and there would be an option for rename. We also have Kelsey Duarte, who is managing the Zoom and making sure the tech is running smoothly. Everybody's muted now, but if you have a question during the Q&A session, please feel free to unmute. You can also use the chat box if you have questions or need anything. If you're comfortable doing so, again, please add your pronouns to your Zoom by clicking those three dots on that video. I want to share a minute about our sponsors because we could not do this without our sponsors. The session today has been generously sponsored by the Office of Research and Statistics. We really want to thank them at CPHA for their contributions to this conference. The Office of Research and Statistics is proud to sponsor the Culture of Data breakout session, and they are part of the Colorado Department of Public Safety. They provide decision makers and the public at large with data on criminal justice in Colorado. They believe their data could be used to help break down silos between public health and public safety, and they welcome you to go to their website at ors.colorado.gov/. Take a look at their published reports and dashboards featuring original data sources and secondary research. Here are just a few of the many topics on which the Office of Research and Statistics provide data: criminal justice contacts with students, impaired driving, impacts of marijuana legalization, and racial disparities in criminal justice decision points. They are also in the beginning stages of collecting data on the law enforcement contacts with civilians, which will be a key data source to facilitate increased transparency in law enforcement operations. The first report based on this new data source will be released in 2023. The Office of Research and Statistics also staffs the Colorado Commission on Criminal Juvenile Justice, whose mission is to enhance public safety and justice through evidence-based analysis, resulting in legislative and policy recommendations. Commission meetings are open to the public, and they welcome your interest in criminal justice reform in Colorado. Please go to their website, ccjj.colorado.gov/ to find out more information. Now I'd like to present the first of our two presentations today. Each presentation that we'll have today in this session will be about 20 minutes. We'll have about 10 minutes Q&A, and then we'll have a break in between the two. The theme of the session is broadening the definition of public health and practice partners. Our first presentation is the NIOSH Well-BQ Survey Instrument, a psychometric assessment among the early childhood education workforce, presented by Jamie Powers, who is a senior professional research assistant at University of Colorado, Anschutz. Thank you, Jamie, for being here, and take it away.
Thank you, Kim. Okay, let's get started here. We just did this, so it should take me no time at all. Okay. Okay, so like Kim said, my name is Jamie Powers. I am a research assistant at the Rocky Mountain Prevention Research Center in the Colorado School of Public Health. And this is a project that I worked on where we were looking at the validity of the NIOSH Well-BQ survey among the early childhood education workforce. And before I get started, using like reactions or something, does anybody in the room work in the early childhood field or with the early childhood field? No? Okay, wonderful. Well, I'm going to give you some background on it so we can all learn about it together. So this is part of the WELL program, the well-being of the ECE workforce in low resource locations. The goal of this project is to investigate interpersonal and organizational level factors that are most associated with worker well-being in Head Start settings. And if you're not familiar with Head Start, those are federally funded settings that primarily serve low-income families. And then this project implements a multi-level, multi-strategy intervention focused on not only the teachers, but on the organizations themselves. And then we also like to assess the factors that lead to successful implementation and effectiveness to improve worker well-being. So this program currently exists in 5 Head Start agencies in Colorado. And this project specifically, what I'm going to share with you today, I'm going to give you some background on the early childhood education workforce, provider well-being, and why it matters for public health. We're also going to look at the NIOSH WellBQ instrument, the survey that focuses on worker well-being and seeing if it's an appropriate tool for the ECE workforce, and then discuss how the WELL program shares data with its ECE partners and how we use that data to improve health. So a little bit of background. There are over 18,000 early childhood educators in Colorado. The median pay for most childcare workers, so you have teachers, food service workers, assistant teachers, admin folks that average around $13 an hour. And then program directors are about $23 an hour. So it is below the self-sufficiency standard in all areas of the state. So this is a low pay, high demand job. They have not only a lot of kids to look after, usually there's about 2 adults in a room to 16 children, but they're focused on academic standards, social emotional learning, literacy, language development. So they have a lot that they're filling in, and it is fairly low pay for all the work that they put in. So why early childhood provider health matters? So they have very high rates of anxiety and depression, about 3 to 4 times the national average. High rates of burnout and turnover. So it's about 30% each year of turnover, and 70% of ECE directors have difficulty finding qualified staff. And I will tell you that this is probably pre-pandemic data. What we're seeing now anecdotally is much higher, some sites 50 to 70% of staff turnover. And this has a really large impact on children. Children thrive in stability and consistency. And so ECE provider health has a huge impact on their social interactions and language development, milestone development in children. So their health has a large impact on the children they serve as well as their community. And then workforce development in this field historically focuses on teaching academic and social emotional skills to children, which is very beneficial, but we know that there needs to be more emphasis on the workers themselves and how we can support them. So there are quite a few popular instruments in the field of early childhood when you look at assessing worker well-being, but a lot of those focus on job demands and resources, job satisfaction, as well as like perceived stress and burnout, all very important things. But we know that there are so many other factors that impact workforce well-being. And so we needed a more holistic approach to adequately assess this. So we looked at the National Institute of Occupational Safety and Health, NIOSH, Worker Well-Being Questionnaire, so NIOSH WellBQ. This is a holistic view of well-being. It has 5 domains you can see here: work evaluation and experience, workplace physical environment and safety climate, workplace policy and culture, health status, and then this sort of larger circle on the outside is home, community, and society. So there's a lot of questions that fit in those 5 buckets that will hopefully assess the overall worker well-being construct. This has been validated with a large national sample from diverse industries. And so we were curious on how well this would actually fit in the field of early childhood, knowing they have very specific job demands and resources. And when we look at those domains, so the first one we look at, work evaluation and experience, focuses on things like job satisfaction, supervisor support, coworker support, really things that create that environment inside the center. Workplace policy and cultures focuses on things like availability of health programs at work, the health culture at work, how busy they are throughout their day, how much their work life impacts their job, and vice versa. Workplace physical environment and safety climate. So this is overall workplace safety, has things to do with work-related bullying, physical violence, sexual violence, just overall safety within their work environment. And then there's one on health status, which has examples like overall health or poor mental health, chronic disease, sleep. And then home, community, and society focuses on financial insecurity and support outside of work within their community. So that's the 5 domains overall that are assessed within the NIOSH instrument. So before we actually wanted to send this survey out, we wanted to get some qualitative formative data. And so we had a focus group to start where we explored the NIOSH domains with about 9 participants from one site, where we got them all together one day and just talked about these big domains and sort of how they see those domains fitting within their centers. So when we asked things about work evaluation and experience, one participant said the impact is what you're there for. You aren't there for the money. So that doing that makes the job worth it. It's actually the greatest impact on my job satisfaction. When we asked about things like workplace policy and culture, they said, I love it. We always have Professional Development Institute, and they focus on things like self-care and how to recuperate in and out of the workplace. It makes me feel like not only do I care about myself, but the people that I work with care about me too. So that was great to kind of just get their ideas on how they see these domains fitting within and if they actually think they are appropriate. And then after that, we conducted some cognitive interviews with early childhood teachers and directors to actually ask about the questions that you would see on this survey. So for example, one question is a Likert scale question that's strongly disagree to strongly agree. And the question is, I am blank with my chances for advancement on this job. And so that person reflected on that question and came back with things that they would think about are, am I able to climb the career ladder? Does this allow me to grow and learn and not sit in one position? They like the answer choices. So that was really helpful to make sure that all of these fit with what they see in their own role. And we did make a few minor tweaks to the questions based on their responses. So then we administered the survey. There's about 73 questions overall and 20 minutes in length. So it is a pretty long survey, but we did incentivize participants in this process for completing the survey. Consent was obtained prior to starting the survey, and it was sent to all of the 5 Head Start agencies that we work with for this project. That includes both urban and rural communities, and we had about 322 responses. So we ran a confirmatory factor analysis, and that was just to see, do all of these items load on those 5 domains adequately? So we cleaned the data and scored it based on the NIOSH scoring guide. So there is a little guide on how you score all of those items and reverse coded the items as needed. We did remove a few items due to low variability. So things like physical violence, sexual harassment, we know are underreported or maybe not reported due to not happening in the site. So there's not a lot of variability. You can't see a lot with those. So we didn't include some of those variables. You can see our results for the factor analysis here. So the first was the 5-factor model with all the items, and then with some of the removed items that just weren't appropriate this time. So fit indices, if you're familiar with them, the AIC, it did get lower, so that's an improvement. RMSEA was adequate for both, and CFI was not quite there, but it definitely improved in our next model. So we are seeing really promising results that the survey is actually analyzing what we want it to, or giving us the data that we want it to. And you can see that here with sort of the correlations. So at the bottom here, each of these circles is those 5 domains, and then the correlations between them, they are all statistically significant. And what is not surprising to us is this sort of work evaluation and experience, work policy and culture, and workplace physical environment and safety climate are all pretty highly correlated because they all sort of deal with that same environmental aspects of worker well-being and how that environment sort of shapes your health. And then health status and home, community, and society were highly correlated, which again makes sense to us because a lot of the resources that you share at your home and your community impact your health. So we think that this would be a great tool to use in early childhood settings to get that holistic view of health. And we wanted to sort of look at our quantitative findings and kind of loop them back to that original qualitative piece that we did. So we started looking at some of the strengths. So you'll see here, so I know this is a little bit small, but 98% of ECE staff agree to some extent that the work they do is meaningful to them, which loops back to that quote I shared earlier about the greatest impact on their job satisfaction being the meaningfulness of their work. 77% of ECE staff reported having access to health education or promotion programs, wellness programs. Again, goes back to that quote I shared earlier that talked about how they feel like their workplace cares about them because they focus on things like self-care. But there are some areas for improvement. The first one here, 24% of staff have been in a situation where a supervisor or a coworker puts them down, were rude to them, or made negative remarks. And that goes back to that workplace bullying. We know coworker support is really important to ECE staff. So having this workplace bullying happening is pretty disheartening and something that I think we can work towards. 25% of ECE don't feel encouraged by or supported by coworkers. So one of the quotes we found from that back in our original focus groups and interviews, I think one of my biggest challenges has been conflict between staff members or conflict that can't be resolved between staff. If they have a conflict just between staff, it's challenging and can get overwhelming, especially when some staff members bring a lot of personal issues to me personally, and I try my best to support. And then we found 7 days of poor mental health. That's out of the last month. So that's a whole week out of 1 month that staff are having poor mental health days. 14% feel clinical rates of anxiety and 13% feel clinical rates of depression. And one of the quotes to support that, if I'm not in a good headspace, I am not going to have a good day. So it's going to affect my job. Mentally, it can be pretty straining. So actually, I think it affects me a lot. And so when you think about not only is it affecting that individual person, but then it affects their coworkers, and then all the kids that are in their classroom too can feel some of that anxiety and the mental health struggles. So it definitely has a wider impact than just one individual person. So some of the recommendations for supporting the ECE workforce, things that we're working for, and then things we recommend for others in the field to also work for. Bolstering supervisor and coworker support, I think, is one of the biggest ones. You could see it in that last slide. There's a lot of workplace bullying. People really rely on their coworkers in this field. There's a lot of people coming in and out of the classroom. So these staff want to know that who's coming in has their back, that they can take the breaks that they need, whether it's a mental break or a physical, bathroom break, that they have that support. So really creating that cohesive environment, I think, is really important here. Increasing disability supports and accommodations. We saw that in the survey that a lot of people didn't feel like they had access to disability services that they needed. So that is a high one on our list. Addressing discrimination. Obviously, we saw that with some of that workplace bullying. We did look at some of this. There are some questions on there that focus on, race and gender, and saw some of that in some of our survey results. And so I think it's something to take into account and really find ways to support these staff to remove some of that from sites. Mitigating workload and increasing time available to themselves. I think this is a huge one. They're in the class for more than 8 hours a day with very small breaks. And so finding ways to take extra breaks for them, or getting people in their classroom to support. Also, they have a lot of things to do outside of class because they have assessments to complete and ways that they're tracking all the things they're doing in the classroom. So giving them extra time to complete those. Increasing pay when possible. I think that's one of the biggest ones. It's definitely one of the most challenging ones to address, but they're a very underpaid field, and that should be increased, definitely when possible. And then mitigating fatigue and burnout, and just having ways that staff can focus on self-care for themselves. So I think the big question now that we have this data is how we share this data with our ECE partners. We do this through a couple ways. The first is, so I should have mentioned in the beginning, this is sort of like a 5-year program. And last year was just a baseline. We just sort of collected data and did program planning. And then each year, new sites move into that intervention phase where we're promoting self-care and health and wellness with teachers and staff and the organization as a whole. So the first year, last year, we shared just aggregated pre-data with all of our sites so that they could see what they were participating in, what the field looked like as a whole. And then as sites move into intervention year, each agency gets some of their pre-data for them to use in a variety of ways. So if we can share site specific, so there are sometimes up to 5 or 6 actual physical locations within one Head Start agency. And so if we can share them at the site specific level, we will. But a lot of the times there's only 1 or 2 classrooms at those sites. And so it's a very small N, and would be it would be unethical to share with such a small N. So at that point, we share agency data, but we share this data so that they can use it in what we call our policy system and environment change process, where we walk them through a wellness team where they can look at policies that they have in place or policies that we recommend as best practices and implement them throughout the year. And so they use this data to make those changes. So you can see this one pager on the right-hand side here. This is an example from Lakewood, one of the Head Starts that we partner with, where we give them the data that they reported back to us so that they can use that to create improvements. So they have really strong coworker relationships there. You can see sort of 69%. But they do have, you can't see on this page, but there are some areas of support that we recommend to them too. And so they use that data in actually selecting their policy changes. And then at the very end of the project, they will receive pre-post data so that they will see the progress that was made throughout the whole process and areas that we can still work on together. And then we also are willing to share our data as sites needed. So we've had sites like Lakewood that have used some of our data in some of their grant applications. And so they can pull directly from what we have to include that and sort of bolster their application. So I think now, Kim, we have time for questions. I have a few discussion questions I have on the screen, but I'm happy to answer any that came up as well.
Wonderful. Thank you so much, Jamie. I really appreciated your presentation. And I was not familiar with the NIOSH survey, so I'm interested in finding out a little bit more about it. And in my own interest, I went and found the CDC site that had more information and posted it in there for other folks.
Okay.
So let me open it up. What questions do you have? Let's start with that first question that Jamie posed. What well-being data stands out to you all as you think about this? Think about the work that you do, think about what you know about early childhood education. What well-being data seems important to you? Feel free to use the chat, come off of mute and/or video. Any thoughts?
I think that 25%, there was like being talked down to, or that survey item was pretty eye-opening. I think that's a pretty high number. I mean, I don't know, obviously no point of comparison. That's pretty fascinating. And then just a point of clarification, when we're talking early childhood education, is this like pre-K educators? What does that kind of look like? I'm new to some of that stuff, so we'd love a little more info on that.
Yeah, so it is pre-K. Yeah, it's usually 3 to 5 years old. Some of these sites do have like early Head Start, which is a little bit younger, but we specifically focus on that 3 to 5 age range.
Yeah, stressful job, I'm sure. So it's yeah, interested to see. I think some of the other stuff that pops out, especially with some of that, like, doing it for the sake of doing it, not for the pay, right? That's kind of, I think that's super exciting. I think it makes sense. But yeah, in that stressful type situation, I see that 25% kind of checks out. And I think excited to see the kind of follow-up you're doing is promoting that data for policy change. That's super cool. Do you guys have any plans to expand beyond, you said 5 agencies you're working with? Is there any chance to expand that, or how does that kind of look? Yeah,
ideally, we will. We have a few programs right now that are modified to this. So work with what we call FFNs, family, friend, and neighbors. So not actual site organizations, but just local people. That's in a rural and southern Colorado. And then, yeah, you're sort of seeing how these 5 years go, what data we get from it. But ultimately, we'd like to expand to many more sites.
Awesome. Fascinating stuff.
Thank you.
That's great. Anything in particular stand out for other folks? Or let's move on to the next question. How do you see that this might be useful in other areas? I know burnout is at an all-time high in governmental public health right now. I think it would be fascinating to have this data for the public health workforce. Chelsea, I saw you come off video. Do you have a question or comment?
I don't. I'm sorry about that. Nope.
No, that's all right.
Particular reason. Just
Perfect. No, glad to see your face.
And I would just ask how widespread this is being used. I mean, I think just kind of as like, I mean, there are a lot of other organizations using this. It'd be great if there was some sort of national comparison database, again, coming in with very little knowledge on that, but thoughts on that?
Good question.
Yeah, that's a great question. I know the original survey that they used to sort of validate this instrument was national, and it was a very diverse field representation. But I haven't seen a lot of niche fields talk about their use of it. I know that there are some other states that are trying to expand this in early childhood, just to try to get that more holistic view. But I think a lot of helping professions, I think public health could use this kind of data that I think would show some really interesting factors that are affecting work when we know fields where people tend to stay because they like the work so much rather than the pay and some of the benefits they receive.
I'm sure it'd be interesting too to see the transition from early childhood education into like the traditional education space of, kindergarten, first grade. And that would be kind of interesting to see how that changes over the life cycle of these students.
Yeah, definitely. And I think what we know from our work that early childhood and sort of traditional education, K through 12, there's a lot of vast differences in sort of their health statuses. One, because pay is such a huge difference. I think in Colorado, it's, the average pay for early childhood is around $32,000, whereas for K through 12, it's around $50,000, $55,000. So it's a pretty big jump. And then, yeah, a lot of the resources that come with school districts don't always exist in some of these smaller ages. I will say in Head Start too, for those who aren't familiar, they do have a lot of national resources to go with them because they are government funded. So when we look at early childhood for Head Start compared to like non-Head Start sites, I think we would see that the non-Head Start sites have actually even higher rates of some of these health conditions because they are usually much smaller sites without the resources to pull from at like a national or state level. So
absolutely. I think when you start talking about K through 12 education, there's such vast differences in pay too in those areas, but in different districts. So that would be an interesting comparison as well. Any other ideas for Jamie about sharing data with early childhood education partners to promote health? Or general questions? I have a kind of a general question, Jamie, not related to that particular one, but I was interested because, you said part of what you're doing with this data is then turning around, sharing it back with Head Start, and also sharing like some kind of individual self-care sorts of resources. What are you doing in the way of actually kind of changing that larger system level at Head Start? How is that informing data around like improving pay or improving kind of the workforce support? So there's that kind of coming at it from that direction also.
Yeah, that is a big part of what we're trying to do. And I will say that is a much slower part of what we're working on. System change always takes a little bit longer, but we have a process that's usually about 6 meetings once a month where we convene a wellness team at the Head Start level, so the agency level, which would trickle down sort of to all the sites that are underneath it. And we meet with the directors and decision makers in that wellness team process and look at their data and then look at sort of state data and best practices around health and well-being and work with them to see how we can implement some of these policy changes that would impact people at the system level and the individual level too. So
I was really struck by when you said that kind of the frontline ECE workers were making around $13 an hour when our current Colorado minimum wage is $13.65. I think it's fascinating. Just, this is an entry level job, almost below entry level from pay, and you can go to McDonald's and make $18 or $20 an hour, and how much that highlights the passion of this constituency as well.
Yeah, definitely. I think one of the groups that they sort of compare their pay to is fast food workers and parking lot attendants, and although those are very commendable jobs too, that these people have children in their care that they're trying to promote, all the social emotional and language and literacy and academic development that you would think they would definitely be receiving higher pay than that. So
yeah, it from a really big systems perspective, I'm always shocked at how little we pay the educators in this country to at all levels, really, to ensure that our next generation is learning what they need to learn and learning critical thinking and developing emotional and social skills. It's really stark. And so I appreciate that this kind of gets to that well-being that can highlight some of those challenges. Any other questions from any participants? Okay. Let's take a little bit of a break. It's currently 3:17, and let's return at 3:25, please. So join us back at 3:25, and we'll jump right back in with our presentation from Ethan Jamison. Thank you so much, Jamie. I really appreciated your presentation, and thank you for being here today. Really important stuff. You bet. All right, see you back at 3:25. Welcome back, everybody. I hope you had the opportunity to get up and stretch and shake your legs a little bit. Welcome back to the second presentation of our second session at our annual CPHA's Culture of Data Conference. Our second presentation is titled Leveraging Coroner and Medical Examiner Data for Public Health Practice. It's going to be presented by Ethan Jamison, who is the Senior Data Analyst for the Denver Department of Public Health and Environment. Take it away, Ethan. I'm looking forward to hearing your presentation.
Great, thanks everybody. Appreciate you having me today. And yeah, we're going to talk about some death data, a little bit of a different side of the spectrum from our earlier presentation. But yeah, just going to get into how we can use coroner and medical examiner data more so than I think a lot of our partners are these days for public health practice, and really kind of switching that paradigm to thinking of coroners and medical examiners as part of the larger public health space. So we'll give you guys kind of a 101 over what coroners and medical examiners do. Again, I think a lot of times, since we kind of live in the shadows, a lot of times there's maybe some different conceptions of what actually the role of a coroner or medical examiner is, look at some of the data that gets collected, again, to kind of add further context to what we do as an agency. We'll give you some case examples from here in Denver about some of those public health partnerships that we've worked out over the last 12 months of my time here, and then kind of point out some best practices for partnering with your local CME office. So just a kind of housekeeping piece. When I say CME, we'll talk about coroners and medical examiners here shortly. We'll get into kind of what those differences are. So a little bit about me. I am the Senior Data Analyst at the Denver Office of the Medical Examiner. There is a terminology that's starting to float around for this type of work. Again, I'm actually housed in the Medical Examiner's office. There's only a handful of positions in the country that do this type of work. The term forensic epidemiologist is somewhat popping up. And so again, kind of a new burgeoning field of work, again, really focusing to have data expertise in the coroner medical examiner office. We're unique as well in that the Office of the Medical Examiner is actually housed within the Department of Public Health and Environment. So that's kind of the work we've done here. It's a newer position, again, building this out. I've only been here about a year, but it's been exciting to be able to pull in some data infrastructure to all the great work done here at OME. And so prior to this, I worked at CDPHE, conducting data collection and analysis of coroner and medical examiner data around the state, death certificate and law enforcement data for the National Violent Death Reporting and state unintentional drug overdose reporting. So have a fair bit of experience working with these folks in one capacity or the other. And again, coordinating kind of state level efforts with all the different coroners and medical examiners versus working housed within an office now. So again, kind of some unique experiences that give me some insights into how these guys think and how a lot of the processes can aid a lot of the public health work that we're focused on in the modern kind of era of public health. All right, so now we'll get into kind of the 101 of what coroners and medical examiners are, what they do, and kind of the nature of the work. So in Colorado, we're kind of a hybrid system, but technically speaking, we are a coroner system. And so the coroner is an elected official at the county level, which is unique and kind of interesting. So we have 62 county coroners. One coroner covers two counties. And then we have our one medical examiner office, which is us in Denver. So around the state, a lot of the coroners, again, are going to be elected officials, whereas a medical examiner's office is a different animal in that those medical examiners are appointed positions rather than elected. And there are significantly higher requirements to be a medical examiner than there are to be a coroner. So to be a medical examiner, you have to be a medical doctor, board certified, and usually a medical specialty in forensic pathology. And then there are even higher levels for accreditation and beyond. So kind of a little bit more rigorous work done, or at least to become a medical examiner than a coroner. Interestingly, a coroner in Colorado, to run for coroner, all you have to be is a resident of the county you live in, a state resident, and then have your high school diploma. So again, kind of some interesting elements in that piece. An important delineation is that the coroner really runs the office and is the head of an office. They're not doing autopsies or doing that type of work. To actually be doing, true medical examiner work, you have to be a forensic pathologist who actually does the autopsies and postmortem examinations. The coroner really works in concert with their forensic pathologist and their team of investigators to then compile that information to complete a death certificate. Again, so a little bit of a important piece there, since the coroner kind of requirements are fairly low. Again, it's not necessarily, it's an important delineation between what they're actually doing. So what are coroners tasked with doing? Again, somewhat of an independent office, usually, you know, directly working with the county commissioners, and are really kind of driven by the revised statutes that spell out the role and jurisdiction of a coroner's office, right? And so really the headline job and title and the main kind of core belief and work of coroners is determining the cause and manner of death for deaths that occur within their jurisdiction, right? Whether it be their geographic jurisdiction or more of a philosophical jurisdiction of what death would be a coroner case, right? And so not every death that occurs in a county is investigated by a coroner or medical examiner. There's a list within those statutes that kind of describe the general guidelines for what cases are coroner cases and which aren't. Generally speaking, it's those deaths that are or may be unnatural as a result of external influences, violence, or injury, or an unattended death. So someone dies at home, not necessarily under the care of a physician. And so it's kind of that broad universe of deaths where we're not really sure exactly where they died. They weren't under the care of a physician at death. And so we need that full investigation to really understand the cause and manner that led to that death. So when we're talking about cause and manner, cause is going to be the physiological description of what led to their death, whereas manner is more of a categorical description. So accident, natural, homicide, suicide. And those are kind of the two dimensions that we're talking about when we're collecting data around deaths. So again, to further drive home some of that information about what is a coroner case, this is a screenshot from those county or those Colorado revised statutes. I'm not going to go through in detail. You guys can take a look at them if interested. But again, there's somewhat of nuance in trying to figure out what cases are in our coroner and medical examiner cases. 99% of them are pretty clear cut. But as an office, our team does a lot of work with hospitals and other counties to determine that jurisdiction, both geographically and if the nature of the death would be a coroner case. So to kind of put this in numbers, last year there were about 5,200 deaths, you know, within Denver, essentially. Drilling down, about 1,600 of those were actual medical examiner cases that were fully investigated by our office. So we're looking about 30% of the deaths within a county are typically coroner cases. Again, this may change by county, but Denver has a good sample size is kind of that rule of thumb for some of these. So that's a good point. But the other piece of that coin is that many of the deaths that are investigated by our office are going to be of interest to public health efforts. Again, we're looking at things like drug overdoses, suicides, firearm deaths, deaths among people experiencing homelessness. So while it's not the full universe of death data, it really is some of these deaths that are, for lack of a better word, of high concern to larger public health efforts, and especially within the last decade or two have come to more so the forefront of public health priorities in terms of preventing death and morbidity from things like drug abuse, mental health, and beyond. All right, so what goes into a medical legal death investigation?
Hey, Ethan, sorry, we just had a quick question in the chat, which I think is relevant. Is it based where the person died or where the person is a resident? So
it's a great, great question, and it's actually neither. So it's kind of in between those two. So it's going to be based on where the incident occurred, right? And so essentially, if someone died in Denver County, or if somebody, let's put it this way, they overdosed in Denver County, but they were transported to a hospital and died in that county, the investigation is going to be where the incident began, right? So, or in other words, if you were shot in Denver and then you were transported to Arapahoe County, that jurisdiction is actually going to be in Denver. So it's really where the fatal incident occurred. Again, it's a bit of nuance. You know, most people die where they live. There are small percentages that kind of fall outside of that. But again, the death piece a lot of times is more heavily weighted to where hospitals are. So again, it really is typically where that incident occurs, the injury or incident occurs. Does that make sense?
It does. Yeah, it
Okay.
makes sense. And it looks like Ty said, got it. Thank
Perfect.
you.
It's a great question, and it's an important sticking point though, for sure. And for different types of deaths, it gets a little bit gray for some of that. So great
And
question.
just to clarify, your residency has nothing to do with whether a CME exam investigates, correct?
Yes, I mean, I think, no, exactly. Yeah. So even if you're, we get out of country people who die or are injured in our area, and then that would become a case regardless. So again, it really is where the death occurs or the incident occurs. Perfect. Thanks for the question. Yeah.
Yep.
So to that end, we'll kind of go into some of the details of what goes into what we call medical legal death investigation, just to give you guys kind of a peek behind the curtain of what this work looks like. Prior to going into this, I'll kind of overview what our team looks like. So we have about 30 people here at Denver OME. We have a team of forensic pathologists and our chief medical examiner, Dr. Caruso, who are really the doctors who oversee the examination. We have a team of death investigators who actually are going to scenes and actually investigating the deaths on scene. We have a team of autopsy technicians who help with the autopsy and postmortem examination. And then we have a team of decedent affairs coordinators who really work with the families and the next of kin to, really kind of help with the movement of remains and kind of foresee how the body gets transported back to the family after our investigation is complete. So again, to that end, someone calls us with information about someone dying, whether it's 911, police, etc. And so death investigators then respond to that scene, take extensive photographs, interview witnesses, work with police if they're on scene, take detailed notes of the scene and evidence, take detailed notes of the body and any injuries that are apparent, oversee the transport of the body, and a lot more. So again, that's kind of that first initiation and first understanding. Investigators are also tasked with identifying decedents. That's a huge part of their work, is figure out the identity of people, notifying and finding those next of kin, and then collecting additional information through interviews kind of after that initial scene investigation. And so then after a person dies and that initial investigation takes place, we take possession of the body. It gets delivered to OME. Again, these are all cases where we've decided it is, in fact, a medical examiner case for the most part. There's some caveats to that, but we'll skip that for now. So they come back to our office. Our team of forensic pathologists review the case information and decide what type of exam would be most appropriate. A lot of times that is an autopsy. There is, again, variety in a full autopsy versus partial autopsy and some other different options there. But the majority of time, then they conduct a postmortem examination, which an autopsy includes a detailed internal and external examination, looking at all the different organs, all different evidence of injury or disease to help get to that final cause and manner of death. And again, in context of the initial information obtained from the scene. And then again, like I said, there is some leeway with how the office decides to investigate different deaths when it comes to that examination, but the majority are autopsy. Following the autopsy, then there's some additional testing and records review, which includes looking at their full medical records, toxicology testing if appropriate. We do a lot of toxicology. The majority of our deaths do have toxicological screens, sometimes histology or microbiology if appropriate. We have a giant x-ray machine that takes x-rays. Sometimes we have specialist consultations and more. And again, so this is all kind of this big web of as dictated by the complexity or nature of the case. But again, there's a lot going into this process, going through multiple teams and taking, the various amounts of time to get to that full picture of what happened and really understand that cause and manner of death. So again, after this work is conducted, then we start to get into the type of data that's collected and then kind of shared out from our office. So the gold standard is the death certificate. I'm sure most of you are aware at some capacity what a death certificate is, but it's an official document created for anyone that dies in our state. And it's completed typically in partnership with funeral homes. So if you've ever seen a death certificate, the first half is typically by funeral homes with the family. And then the second half is by the coroner, or again, those cases where if they're under the care of a physician, it would be completed by them. It contains key identifiers, demographics, location data, et cetera. Again, those cause and manner of death specifics we've been talking about, and kind of additional contributing factors. It's a pretty concise document describing the individual. We submit all those data or all those death certificates to CDPHE, the state health department, because they are the steward of those data, who then share them with CDC to get that ICD-10 coding, which is essentially a standardized coding for cause of death. Those ICD-10 coded data are then used at the local, state, and national level for analyzing deaths. Again, this is the gold standard used for years and years and years, comparing deaths and looking at public health surveillance for cause of death. Extending that to kind of OMEs and coroner's offices, another resource that's created is the autopsy report. And so again, this is kind of going to be the next more detailed version of the death certificate that has that detailed summary of whatever they found in that postmortem examination, really looking at all those contributing conditions that would have highlighted to the death, that would have contributed to the death. Includes pertinent medical history and summary of events that kind of were covered in that investigation. And then it includes that opinion of the forensic pathologist, which again is really kind of showing the distillation of all that information and how they arrived at their final opinion. Again, it's like the next iteration of the death certificate. In Colorado, autopsy reports are actually public record. And so that's kind of an interesting little factoid that not everybody knows, and they're covered by CORA. And so that is technically a public record, where death certificates are not. It's an important delineation. Again, so those are kind of the two gold standards that the majority of coroner and medical examiner offices are going to be working to create in terms of final products and reports, and a lot of times where we think most of the data lives. But in my role as a data analyst for Denver OME, there's so much data beyond those kind of traditional sources. So again, most CMEs these days have a case management system of some kind. And again, there's a lot of robust information going into there outside of what gets in those final reports. Basically, all that information collected through the investigation is going and being collected in some capacity, often in greater detail than what makes it into those final documents. And again, if you're asking the right questions, a lot of these can be leveraged with data analysis and support to ask these larger public health questions that we sometimes want to know and maybe don't have answers for with other reporting sources. So kind of some of those examples that we've seen from our office, or at least ideas of stuff we could do, is looking at types of drug paraphernalia found on scene to understand the route of administration for drug overdose deaths, right? So this kind of shift that we're seeing in a lot of our overdoses is less people using syringes or, for lack of a better word, shooting drugs, transitioning to smoking drugs more commonly. Again, we're seeing that through the use of scene information data for a lot of these deaths. Another thing is looking at recent contact with hospitals or other institutions. So you have someone who dies and you want to retroactively look at who did they have contact with as points of prevention. Again, that we have some cool projects in the hopper that will detail similar things to see, looking back at these deaths, who do they have contact with? Looking at specific vehicle injuries, things like Lime electric scooters has come up a lot, or looking at unique pedestrian locations where people are hit. Again, kind of having these pointed public health questions that we can see in death data, or even going on to look at how naloxone gets administered and what deaths may have that present. So again, a lot of things that really just take having the right question and really diving into that data to better understand it and to inform public health work. So again, just something beyond those data focused pieces. Again, most CME offices have forensic pathologists, either if not on staff as a contract employee, and they're invaluable subject matter experts for a lot of clinical and medical issues. Evidence of that in DDPHE is that our current chief medical officer is Dr. Sterling McLaren, who is one of our forensic pathologists / medical examiners. So again, she has a wealth of resources in terms of being a medical doctor on hand who can answer a lot of questions about clinical or medical related issues. Again, the education and training for these forensic pathologists is above and beyond what a typical medical doctor has to go through. So again, they're a great resource on just being experts in that realm of public health, the clinical side of that. Additionally, death investigators are a lot of times seeing, they're the boots on the ground work, seeing the worst of the worst on some of this stuff and seeing what these death scenes look like and seeing the next of kin and kind of living the unfortunate reality of a lot of these causes of mortality. OME is also unique for Denver. We have an innovative team, the Family Advocate Support Team, called FAST, who actually is, one of the first in the nation to take, this to the next level in terms of following up and outreach with families and connecting them to different nonprofits and different, kind of literally kind of like small scale post-pension work for a lot of these families and connecting them with resources. So again, that's another wave that's building within medical examiner and coroner communities to really kind of work with the families more so after the death than just doing the investigation. So springboarding off that, now we're going to talk about, again, some case examples from my work here at Denver Office of the Medical Examiner, partnering with Denver Department of Public Health, and some of these ways where we've leveraged the data for public health action. So one of the first ones was this last year, looking at deaths due to cold weather. So there was questions that came up, especially with some days that were sub-zero temperatures, where they wanted to better understand hypothermic deaths or deaths related to environmental exposure, and use that information to leverage decision-making about the operations of city and county of Denver warming centers, right? So we did an analysis, looked at all those deaths, and also overlaid some temperature data so they could start to understand, maybe get an idea of a threshold. Again, so as everyone knows who's working government or nonprofit, you always have to meet the clinical insights and the data with practical capacity. So again, it's part of the conversation. It's not always going to be, a direct interpretation of the data as dogma, but again, it's part of that conversation to meet practical abilities with data-driven evidence to better prevent these deaths, or at least create programs to prevent them. Another case example is coroner and medical examiner offices are great for looking at novel psychoactive substances, or another word, new drugs that may be entering our communities and risk of causing fatal overdoses. So we're hit up pretty commonly for looking for these substances. So things like xylazine, which you may have heard of in the news, or pyro, which is a new synthetic fentanyl that comes through. And again, we get requests from community partners who work with people who use drugs, national experts who see it in other states, and local leaders to say, hey, what is the thermometer on this drug in our deaths? And so we can start to kind of ask that question and help contribute to early planning if we do see dramatic shifts in our drug overdose trends. The other cool thing that we have, at least in our office, is we participate with NMS Labs, which is the largest toxicology lab in the country. And so our data also contribute to national conversations about novel psychoactive substances. So again, not only are we contributing to early alerts in our local communities, we're also sending that data out in some capacity to national partners. Another example that's been a really cool collaborative thing here at Denver, within the city and county of Denver, is this public health harms hotspots mapping project. And so the Department of Safety did a project like this with some of their crime data. And what they wanted to do is map multiple indicators of public health harms to really identify hotspots in the community. With those hotspots, they're assessing if there's a role of built environment or persistent community drivers, and asking the question, why are these areas, coming up again and again for seeing these different public health harms? And again, OME data was a big contributor to understand where some of these deaths of concern are showing up. It also brought together all the different city and county agencies to ask the question of, what are we already doing? Can we combine efforts and really kind of try and, in addition to mapping out the harms, we're also mapping out the efforts from the county level and asking, what can we do more? What aren't we doing? And again, it's an ongoing effort. So it's a lot of work being done on that front. Okay, so wrapping up here, just a couple more points to drive the point home that CME offices really are a key partner for a lot of public health planning. I think in the history of a lot of this stuff, CME can kind of be gray, whether it's a public health or a public safety agency, and in some capacities we're both, right? But again, I think it only is mutually beneficial for public health folks to strengthen that connection and have a strong relationship with your coroner force, all these different reasons that we've talked about. The other side of the coin is that CME offices are often underfunded and understaffed and lack the appropriate resources to kind of deal with a historically noted increase in our caseloads across the country and the state. And again, since typically, Denver's different than others, CME offices are usually independent entities, so you kind of have to meet them where they're at and really kind of be flexible with them. Something that's, I think, a great way to kind of open that door is help finding opportunities to share or provide resources. Again, noting those issues. There's tons of funding out there for a lot of these guys. The CDC efforts to support CME offices is really growing, but I think a lot of times they may not know that it's available, may not have the capacity to apply for those grant funds. So I think as a public health partner, that could be a great start. It's just connecting local coroners with available funding as a partnership, right? And again, another thing a lot of them lack, noting that I'm one of few data analysts in the country, is data analysis support. So the ability to even really dig into their data. So again, that might be another opportunity to say, well, public health often has robust data analysis capability. So maybe there's a way to partner there. Regardless of what that looks like, having a transparent communication is key to building that trusting relationship. And just kind of, again, we're both, government entities trying to help the community in some way or another. So I think that's where you want to start with these conversations. Just one more plug too. We have, again, since we have a robust data program, we've been building up some of our public facing data resources. We put out an annual report. A lot of CME offices complete these, so that can be a great place to start just to understand the data and work done by a local coroners team. We have public data dashboards and we do ad hoc data requests. And then the link for that is our webpage is there. So I know I went over, sorry.
That's okay. There is a couple of questions in the chat, so I want to make sure that we have time to get there. Thank you for that excellent presentation. I really appreciate it. I learned a lot myself. I'm a longtime public health nurse, and so it was super interesting to think about the opportunities in those collaborations. So thank you. Tate, we have a question in the chat. How fast can the drug overdose data be to classifying new synthetic opioids? Yeah, it's a great point. And that is a caveat with that data. So we're, beholden to the time that toxicology takes to run, right? So a death occurs, we do those examinations usually within a couple of days, and then we run that toxicology, which unfortunately it's getting better, but there was historic issues again with 2020 and the logistic thing that everyone has logistical issues, right? So toxicology was taking longer. It can take up to 60 to 90 days. So again, there is a delay. It's not real-time data, but it's still something that we have that thermometer to say we're seeing the data, that this drug in a person's system, which is unique because again, a lot of other systems are not as well equipped for that. So it's not a perfect system, but it's one of the few ones that we do have to kind of see some of those data again, even if it is within that 60 to 90 day window. And again, sometimes it's faster, but it kind of just depends on the logistics. But the number usually we put out there is about 60 to 90 days for that toxicology. And follow up to that question, what does the process look like when a fatality has more than one drug type? Sure. So yeah, and there's been historic efforts, I think, starting 2015 to improve our death certificate reporting with medical examiners and coroners to put those specific drugs on there. So again, it's going to be all part of this process. Our forensic pathologists review the toxicology in connection with the full exam that was given and decide what drugs from that toxicology, typically based on concentrations, contributed to that death. And so analytically from my end, we're going to count any and all of those substances that are noted as causing death in some way or another. So typically you'd say, how many deaths are related to methamphetamine? You're going to count every death that has meth on that cause of death on the death certificate. Same thing for fentanyl. And again, they're not mutually exclusive groups. Okay. Typically, we see the majority of overdose deaths are from multi-substance or, related use. And so again, they're going to be counted. Both are going to be counted. Okay. If that answers your question. Yes, I believe so. Tate, let us know if you didn't get your answer or your question answered. There was also just a comment from Nina. Thank you so much for the presentation. As someone who used to work with this realm, I think it would be great to present at CCA. I'm assuming you know what CCA is. Yep. Great. No, appreciate that. Yes, for sure. Appreciate you, Nina. Any additional comments or questions for Ethan?
Hi, Ethan. I was excited. I signed up to check this because I was interested in your presentation. I used to work with our local coroner with suicide-related data, and I am curious your experience with the autopsy reports and the like case management system. What format the data is generally in? Is it more in narrative text that you are having to dig into? You know, what does that process look like?
It's a great question and a great data focused question. So I think autopsy reports, like, you know, typically are unfortunately not in a good machine readable format. So again, that's not something that from a data perspective I want to lean into too much, and I typically don't. We're lucky to partner with a there's a handful of, it's kind of a cottage industry of people who provide case management systems to coroners and medical examiners. One of them is WellBQ. And so I'm lucky enough to be able to pull all of the data from a SQL database from the back end, and typically lean into more of that coded data. There is still, I do use a fair bit of narrative review and text string searches, which is never, you know, that has its own caveats as well. For some of the data, we do lean into that type of work. The nice thing is in the medical examiner and death investigation world, it's pretty standardized language. So that is kind of on the positive side of limiting some of those issues. But yeah, it depends on the question you're asking, but for the most part, we're not reliant upon, you know, abstracting or collecting data from an autopsy report. It exists in an electronic case management system. And I think some of that funding from CDC is going to get more and more counties able to have an electronic case management system. I think it's more than, I think the majority do have some sort of electronic data collection. It's not as pen and paper as it was, you know, probably 10, 20 years ago. But again, I think more people are going that way. So that's where I would say I think there is more capacity to leverage that electronic data case management system rather than being reliant on static documents. It's moving that way for sure, especially in bigger agencies.
Awesome. Thank you, Ethan. There is one more question from Ty in the chat box. I'll read it out loud, but I'd love for you to answer in chat so I can move us to closure here.
Perfect. Yeah.
Do counties have data sharing agreements that would enable them to see if other counties are experiencing similar death rates like fentanyl ODs or infectious disease? I think that you may have a perspective on that, considering your previous role at state. So would love to hear your response to that. All right, in order for us to get out of here on time and enjoy what's shaping up to be a beautiful afternoon and a beautiful weekend ahead, I've got a couple of announcements for you. First of all, I want to thank you for attending this session that is sponsored by Colorado Public Health Colorado Public Health Association. And specifically, this session was sponsored by the Office of Research and Statistics. I just want to take a moment to again thank our first presenter, Jamie Power, who shared information on NIOSH WellBQ Survey Instrument, that psychometric assessment among early childhood education. And again, another thanks to Ethan Jamison, who presented leveraging coroner and medical examiner data for public health practice. We never have enough time to hear all the wisdom from our speakers, but I do appreciate your all engaging in these conversations. A few short announcements before you head out for this afternoon. Slides and any additional handouts the speakers have are provided on that SCED app, or the SCED where you find your schedule, the SCED on the internet. You will receive a conference evaluation form via email after the conference is over. Please, 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 please fill that out, because this is how we continue to improve these offerings for you into the future. It's very helpful for our planning committee, and we do absolutely review that information. There will be a raffle for everyone who completes the survey within 2 weeks, and you could win one of two $50 gift cards. So that wraps up our today's session and the first day of Culture of Data. We hope you have enjoyed the first day of this conference, and we are excited to see you back here tomorrow. We'll be picking back up starting at 9 a.m. tomorrow with the Emerging Leaders Showcase session beginning at 9, and features 3 presentations from rising stars in public health on the topics of environmental data justice, youth-driven community planning, and access to intimate partner violence shelters in Colorado. We hope to see you there and for the breakout sessions that will follow. Please see that schedule for tomorrow on the SCED conference website. Thank you for being here today, and have a wonderful Thursday afternoon. Thank you very much. Thanks, Ethan. Thank you, Jamie.
Thanks so much. Appreciate you guys.
Indeed.
Thanks,
Thanks for being
Tim.
here. Have a wonderful afternoon.
Yeah, you guys too.
Thanks, Kelsey, for your support too.
Thank you. Thanks for moderating and leading some discussion here with everybody.
Indeed. Good discussions.
Well, it was really great to see you and
Good to see you too.
do this session with you. I hope you have a great rest of your day.
Thanks. You too. Have a good one. Thanks, everybody.